My name is Jessica Hubbard, and I'm a manager for Community Education Department at MDA. We're thrilled to have you join us for MDA's virtual learning series on DMD. We look forward to seeing you on December 11th for the live Q&A session with presenters from the series. This learning event is part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. We would like to thank our sponsor, Regenx Bio, for supporting this virtual learning series. And for nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. Now it is my pleasure to introduce today's speakers, Kelly Maynard and Amy Atkins. Kelly launched Little Hercules Foundation on January 1st, 2013, after her youngest son, Jackson, was diagnosed with Duchenne muscular dystrophy at the age of 5. After desperately searching for a treatment for her son, only to find none, Kelly decided to leave her career and invest all of her time and energy toward Duchenne. As president of Little Hercules Foundation, Kelly focuses on patient access and assisting other Duchenne families. She advocates with regulatory agencies regarding drug approvals, developments of critical partnerships with Duchenne and rare disease community, and testifies on legislation that directly impacts families and patients living with all rare diseases. And Amy joined Little Hercules Foundation to use her skills and experience to help individuals and families impacted by rare disease. Amy's only child, Elijah, was diagnosed with DMD at the age of 4. She has been impacted by Duchenne throughout her entire life, having survived the loss of both her brother and a cousin to the disease. Amy has spent her professional life working in various capacities within both public and private nonprofit organizations focused on serving individuals with disabilities. She has a passion for helping people obtain access to the things that they need and has extensive experience with coordinating community supports, locating and arranging necessary paid services, and navigating benefits such as Medicaid, Medicare, and Social Security. We understand that this is a condensed version of the typical presentation that you guys would give a rare disease organization due to the time constraints of recording and this virtual learning series. So at the end, I will have they will share their contact information, and I will also share a way for you to send any questions that I can get answered by both Amy and Kelly after the presentation. And with that, thank you both for being here today, and I will turn the time over to you.
Thank you, Jessica. And can you see my screen?
Not quite yet.
Okay, let me make sure and get this shared. There we go.
Now we can see it.
All right. Well, thank you so much for having us. We're excited to do this presentation, and thank you for that wonderful introduction. As Jessica stated, we're going to talk today about navigating insurance coverage for approved treatments in Duchenne. So for today's training, we thought we would just start with an overview of health insurance. We'd include the types of coverage, what the coverage process looks like, and a bit of information on appeals. After that, we'll highlight some current issues that patients are having regarding access, and then we'll follow that by how the Little Hercules Foundation works to address some of those concerns. So to start out by types of health coverage, and this is not an all-inclusive list of coverage, but it's the vast majority. So we are going to talk about these 5 types of health coverage. Those would be your employer-sponsored, your marketplace, also known as exchange plans, Medicaid, CHIP or Children's Health Insurance Program, and then lastly, Medicare. So starting with employer-sponsored plans, these plans are employer provided, so that coverage is tied to your employment. Most often, the cost of premiums are shared between both the employer and their employees. In this scenario, the employer selects the insurances and the options available. So your options can be limited to what your employer selects. And then also, these plans can be either fully insured or self-insured. In fully insured plans, these employer health plans are regulated and they're overseen by each state. Each state has an insurance commission that regulates the insurance, and all of which are members of the NAIC, or the National Association for Insurance Commissioners. Many employers, however, choose to self-insure rather than purchase health insurance for their employees. And actually, it's a rather large number. It's about 67% of them. So in this setup, the employer pays the healthcare claims for all employees as opposed to a health insurer holding the financial risk. The Department of Labor, instead of the Department of Insurance, provides oversight to these plans, which do have less patient protections than the fully insured ones. And I will say that, sometimes it can be hard to distinguish whether your employer plan is fully or self-funded. And it can be further complicated to figure that out because companies will typically contract out with an insurer to act as their benefit administrator. Sometimes the best way to find that information is to either use your plan documents or inquire with your human resources department. Next is the marketplace plans, also known as ACA plans. And these plans have to be approved by each state health insurance or state insurance department before they can be sold on the marketplace. You can find these plans on healthcare.gov, or in some states, they run their own marketplace. You select the company and the plan, and then these plans can be subsidized based on your income. Open enrollment is annually, and for the federal marketplace, that's November 1st through January 15th. Some states have dates that are a little bit different than that. You can enroll outside of these dates, but only if you qualify for a special enrollment period. And that special enrollment period would be because you did things like got married or had a new baby, or you're losing your health care coverage. The next is Medicaid. Medicaid is the largest source of health coverage in the United States. Actually, it covers millions of Americans, approximately 1 in 5. Medicaid's jointly funded by the federal government and the states, and then it's managed at the state and local level. It covers low-income people of every age, including qualified pregnant women and children, individuals who receive SSI, or supplemental security income, and other groups as determined by the Medicaid agency, such as certain disabled individuals. The coverage through Medicaid is provided through managed care or direct payment, also known as fee-for-service, or a combination of the two. So in managed care, private insurance companies agree to provide Medicaid benefits to beneficiaries in exchange for a payment, usually monthly, from the state. These private insurers also offer multiple types of health coverage. So they offer both employer or Medicaid plans. So one thing to make sure you're aware of is that the coverage policies might differ from those insurance companies based on the type of coverage they're giving. Next is the Children's Health Insurance Program, or CHIP, and this is coverage for children whose families earn too much money from Medicaid. Children can be covered by CHIP until their 19th birthday. And in order to qualify, children have to be uninsured, determined ineligible for Medicaid, and not covered through a group health plan or other credible health insurance. The requirements do differ from state to state, and some states even charge a premium, but if they do, that cost is a maximum of 5% of the yearly family income. And application for the CHIP program can be made at any time. Okay. Lastly is Medicare, and Medicare is the federal health insurance program that covers older adults. But what some people don't realize is that it also covers people with disabilities, and it covers them 24 months after becoming eligible for Social Security Disability Benefits, or SSDI. So that's SSDI, not SSI. And It's after 24 months of having SSDI, with few exceptions for certain conditions. In Medicare, there's a choice of delivery systems, either traditional Medicare, where Type A covers hospital, B, medical, and D, prescription coverage, or a Medicare Advantage plan, which are offered by private insurance companies. So now that we've discussed types of insurance, let's talk about what the coverage process should look like. And it can look just like this. You meet with your care team to discuss and decide on the best treatment options and determine that treatment. Your doctor writes a prescription and then submits it to insurance. Typically, there's a start form from the drug company that's completed by you and or the physician. And then a prior authorization from your insurance company may be required. That prior authorization can include the need for medical records, such as genetic testing information, and other records, such as physical testing results. A letter of medical necessity may also be included. The doctor, patient, and drug company work with insurance to obtain coverage. Everything is good, and approval is received, and the patient receives treatment. And yes, it can work like that. But oftentimes in rare disease, that's not really the case. So for costly treatments, it can look like this. The doctor orders a medication and prior authorization is submitted, and then you receive a denial. You should receive the decision and be notified of the reason for denial, as well as information on the appeals process. Read the notice carefully when it comes and follow up with the clinic and your case manager at the drug company if you have one for guidance. Little Hercules Foundation also works with patients and families to navigate that appeals process. A peer-to-peer may be an option that your doctor wants to explore. A peer-to-peer review is a discussion between the prescriber and another physician at the insurance company. You may have to go through multiple levels of internal appeal with your insurance company before then an external review is requested. At external review, an outside organization or group known as an independent review organization, or IRO, that's not affiliated with your insurance company, reviews everything that's previously submitted and also any new information that can be submitted, and decides to either uphold the insurance company's decision, that means it remains denied, or reverse their decision and approve. Their decision is final, and at that point, appeals are exhausted. I do need to say that depending on your coverage, the process might look a little bit different. So, for example, Medicaid has a process called fair hearing, which is after you've exhausted your appeals with managed care. Here's some things that you can appeal. The first is your request for a healthcare service supply or prescription drug is denied. A request for payment for a healthcare or prescription drug you already received is denied. Your request to change the amount you must pay for a prescription drug is denied. Or you're getting coverage for an item and then the plan stops paying. Just because something's not covered under policy doesn't mean it won't be covered based on medical necessity. With appeals, you always want to make sure you're on the same page with your medical team and anyone else, like the specialty pharmacy or the case manager from the drug company for your medication, and keep them involved. This is just a list of some of the most common reasons for denial that we see. The first is not medically necessary, and it's really the most common one that we see. The next, services are experimental, investigational. And this is common with drugs that are approved based on accelerated approval and new expensive treatments for rare disease. The next, step therapy requirements. You need to try a cheaper drug before you can try the more expensive one. The next, off formulary. The medication is not on the plan's drug list and they won't pay for it without an exception. Effectiveness has not been proven. This is very similar to experimental investigational. Next, not covered or excluded from the benefit. And we'll talk about this a bit later under coverage challenges. And lastly, lack of documentation. Sometimes the necessary documentation was not submitted, but sometimes it's also could be a way for the insurance company to use to say no instead of admitting that their coverage policy is restrictive. For example, requiring results of a walk test to make a determination in someone who uses a wheelchair who obviously cannot walk. So those are just a list of some common reasons for denials. And now I'm going to hand this off to Kelly to discuss options that you would explore beyond appeal. Go ahead,
Thanks,
Kelly.
Amy. Thank you. So what are your options when external review is not successful? Sorry about that. Um, outside funding from charitable organizations, these would be organizations like the Assistance Fund or Pan Foundation, just to name a few that you are probably most familiar with. Um, Sometimes the applicants that come to us for help, they want to draw media attention to the fact that their child has been denied a medically necessary treatment, and they want help doing a change.org petition. We don't like to use that option. Let me say, we don't like to overuse that option because it does take some targeted, it requires a targeted approach to actually get people's attention. And a lot of times, like a change.org, you would need just about everyone that signs your petition to put like $1 or $2 behind it in order for it to gain traction. We also assist in helping families get in touch with their elected officials, whether those are state or federal, depending on whether your health plan is either federally regulated or state regulated. And we highly encourage all clients to file a complaint with their state insurance commission or any other regulatory body that applies to your case. Some of these cases can get really complex and involve multiple regulatory bodies. And then lastly, you always have the opportunity and the option to file a civil action in a court of law. Obviously, that's not a viable option for a lot of people, but it still is an option. Next slide. So what are the coverage challenges we see for patients, in addition to the ones that we've already sort of touched on? Copay accumulators. These are a tool used by some health plans and some self-insured employers to basically shift the cost share, more of the cost share of a really expensive treatment onto the patient. And what happens is they will basically laser out a certain treatment, and they will require you to work with a third-party vendor. Some that we are familiar with is Savon SP or Prudent RX. And what these third-party vendors will do is they will go to the manufacturer of your treatment and they will force you to exhaust all of your patient assistance funding before the health plan or any other payer is involved in the transaction. And a lot of times, well, most of the time, these copay accumulators do not count towards your out-of-pocket cost share. The next is treatment carve-outs, the benefit design. A lot of specialty pharmacy drugs can be very expensive as a whole category. And so what a lot of payers do is they put their specialty pharmacy sort of treatments in a tiered program, and it's at a tier that really isn't covered, or if it is covered, it's not covered effectively for you. We've also seen condition or diagnosis carve-outs where a self-insured employer or health plan will I take that back. We don't necessarily see this in private health plans, Amy, right? It's more on the self-insured employer side.
Mm-hmm.
They will carve out whole diagnoses. So we have seen and have had families come to us where SMA has been completely carved out of their benefit design, basically rendering that patient uninsured for their diagnosis. And then we talked a little bit about alternative funding programs. These are, like I mentioned, these are third-party vendors that payers will contract with in order just to basically, the bottom line is to help them save money on prescription drug cost. And so, how do we assist patients and families when they come to us? Well, we assist them in multiple areas. The most popular is when a patient or a caregiver gets a denial, and they just really don't know what to do, and it's really frustrating and stressful. So we have an application on our website where you can go and apply. You can upload the documents that we need, and then your case will be triaged and it will be assigned to the appropriate case manager with the particular expertise that you need. If there are multiple things that are indicated on the application as a need, then sometimes we'll assign it to more than one case manager, and those two case managers will work the case together. We help you navigate your insurance options and the whole insurance process. We help you with your appeal. So when I say help, we will help write that appeal for you. The goal is to make this process as easy as possible for you. We understand that it's very stressful and time consuming. And as moms of children with Duchenne, we know that time is our most precious commodity. And so you shouldn't be receiving these denials in the first place. So spending a lot of time, getting access to what is medically necessary, that is incredibly important for us to assist you with. We can also assist you with other options for pursuing coverage. So a lot of times people are just underinsured and don't have the best coverage. So we can help you navigate what your options are for that. And then we take all of those cases that come to us from the community, and we form our policy and legislative priorities for either the current year or the following year, and we continually work on those that improve patient access for rare disease patients. We also do direct engagement with payers. If we see a coverage policy that is issued and it is very restrictive or it is harmful, which we have seen a couple of times, we will directly engage with that payer, and we will go to the upper levels of executive level. And then we also work alongside other organizations to address access barriers. It's the next slide. Is that one mine? Oh, and so that's the end of our presentation. As Jessica said in the beginning, this is a very condensed version of the presentation that we normally do for our fellow rare disease advocacy orgs. And Jessica has graciously offered to field any questions and get them to us. So if you have any questions for either Amy or I, we understand that these can get really complex and it's hard to answer them in a format like this, but we do want to get you any answer that we can. So, and with that, I'll turn it back over to Jessica.
Thank you so much, Kelly and Amy. What a wealth of information you shared in a very condensed amount of time. We appreciate that so much. And thank you both for your tireless work that you and your team do for Duchenne. We're lucky to have you guys in our corner for sure. Yeah, and then of course, reach out with any questions, and I will make sure to get those to Amy and Kelly. You can email those to jhubbard@mdausa.org, and I will be sure to compile all of the questions and get those over to Kelly and Amy to get them answered. And of course, we would like to welcome you to join MDA using the QR code on the screen or by going to mda.org/join-MDA. It's free, and we'll keep you up to date on our latest research and educational programs. Again, we would like to thank REGENXBIO for supporting this virtual learning series. And if anyone has questions regarding any of the programming or anything else, then you can always contact MDA's Resource Center at 1-833-ASK-MDA1. And then we look forward to seeing everyone for the live Q&A on December 11th at 4 p.m. Thank you again, Kelly and Amy, for your time, and this concludes today's recording.